Hey,
Hi, how
well,
are
I'm good, thanks. And you?
you? Yeah, not too bad, not too bad. um, just waiting for people to join. We've had about 500 people register, but I know a lot have said that they will need to catch the recording. So, um,
Okay.
for people to jump on and then we'll get going. And I think we'll just keep it pretty casual and
Yeah, casual's good.
casual's good. um, the numbers decline. Good. Well, I might just actually honour your time and I will just introduce you. For those that don't know you, you're obviously a specialist general practitioner and you're based in the Sunshine Coast in Queensland, Australia. Um, and what you have been doing is pioneering work in the area of mould illness. Not only are you a fellow of the Australian College of Nutritional and Environmental Medicine, uh, but you're also a founding member of the Australian Chronic Infectious and Inflammatory Diseases Society. Great to see that happening. And the International Society of Environmental Acquired Illness. So I think it's fair to say you've got a very special interest in this area. And what I really appreciate you doing this webinar because I've done an awful lot of practitioner training in the area of mould illness. And I think your course is the most practical. One of the challenges that we face as practitioners is every client is in a different house and environment. So we need a certain level of training of the client in order to actually get anywhere. So I would encourage anyone that is either suspecting they're in mould or working with people in mould to seriously consider your course, which I think is also very reasonable. Um, so that's a little bit of intro. Is there anything else you'd like to add, Dr. Gupta?
No, that's fine, thanks.
Yeah, I don't like talking about myself, so most people know me because you've got the email from me. But I thought I'd just start off with trying to identify mold illness. I mean, one of the challenges is clients come into our practice with complex symptoms and often limited amounts of money to spend on testing and so on. And I'm just wondering, what are the couple of symptoms, and I know it is a systemic condition, but when you start hearing certain words, what makes you think mold as opposed to other chronic infections, for example?
Other chronic infections. Oh, I see. Yeah, okay, so that's a good question. So, I mean, often when you're seeing people for the first time, you're trying to differentiate, I guess, not just chronic infections, but also just more basic functional medicine problems. And so, if you don't mind me answering a slightly different question to start with, which is how
Fantastic
do
question. I should have asked. That's
That's
absolutely
all right.
fine.
So how to first differentiate it from more of a general functional medicine problem that may involve, for instance, the microbiome, or some fairly simple nutritional deficiencies and so on. Well, one of the things would be just the complexity and the severity of the symptoms. And so if someone's got, we call it a multi-system, multi-symptom illness. That was Richie Shoemaker's words, where basically you're not just looking at one body system or two body systems, you're looking at a range of different body systems. So that would be a tip off to the fact that the person may be more in the biotoxin quadrant, if you like. So I consider them to be separate quadrants virtually. And there's going to be crossover for sure. Like I'm not saying that people who have a biotoxin problem don't benefit from functional medicine protocols at all, or that those who are doing well with functional medicine protocols wouldn't benefit from just making sure that they're keeping free of mold. I think that those things are right. However, generally speaking, any particular client's illness will be more centered in one particular quadrant, if you like. And so the complexity and the severity gives you a tip off as to whether it may be a mold related problem. then going into the history and asking more specific questions about the exposures, the environmental exposures, will be very helpful. And then if you've decided that it appears that the client's illness is more in what we call the biotoxin quadrant, and one way of knowing that is just the fact that they've given a very good trial to appropriately designed functional medicine protocols, and for at least 6 to 12 months, and they've had no response. That would be a really, that's the in practice way of differentiating, is that, if they've been given a good trial, and I do think in most cases doing some basic functional medicine work with almost any client is appropriate. But if there's clearly no response, you're then thinking that they may well be in the biotoxin quadrant, or they may be in the emotional quadrant more. And so if you then start going into that quadrant and then wanting to differentiate out of that, whether it might be mainly mold or whether it might be mainly stealth infections, there are some symptoms. I mean, the symptoms are very interchangeable, though. They're very, very overlapping. So I wouldn't say it's easy just on the basis of symptoms. However, there are some that are more suggestive of water damage buildings and mold. And so one that's been spoken of is like a vibratory sensation or static electricity shocks. Those would probably be the most two very specific ones for mold. And the other thing is insomnia is very, very common, I find.
Yeah. That's fine.
That's a really, really common one. Yeah, I mean, it's very common in tick-borne infections as well. But it seems to be somewhat pathognomonic of mold, because mold somehow just seems to totally interfere with the sleep pathway. So those are some of the things. And then, if someone's got very severe headaches or neuropathic pain, which basically means like a burning pain shooting down the arms or legs, they can cut. You can get those with mold illness, but it would be quite severe. So generally speaking, I would say that those would point more towards a tick-borne illness. So there's some little things like that, but I think in general it's going to be the environmental history and asking them about their exposures and the timeline of their symptoms and so on. That's probably going to be the most benefit.
Yeah. Okay, great. And I guess a lead-on question from that, and you have sort of touched on it, is how can are there any other tips in terms of distinguishing mold from other chronic infections such as Lyme and Co? And do these things often travel together? I mean, there is a perception that they do often travel together with Lyme and Co and retrovirus.
Yeah. They often travel together. I mean, obviously, when you're doing a full environmental history, you'll be asking people also about the timeline of their symptoms with regards to which buildings they were living in. And often one of the most specific things to identify that that buildings and dampness and mold have been an issue is that there will be a pattern of the symptoms getting worse with exposure to certain buildings that had signs of water damage. So that's going to be one of the most specific things. I mentioned some symptoms there, but I'm going to say overall, I'm not sure that it's that easy to differentiate from symptoms. I haven't found it to be. I think I've definitely found that you need to do a very thorough environmental history, and then you generally then have a strong hunch based on that, which you can then back up with tests.
And often when I'm doing an environmental history, and I'm not sure about anyone else, but just to further that question, there's an awareness of mold. So people say, oh, there's a crack in a tile in the shower, and therefore suspect mold illness, whereas others clearly have, rising damp and, all sorts of other issues. So there's obviously a spectrum. Does a little bit of mold exposure with a cracked tile in a shower have the same potential as visible black mold?
That's a little bit of a tricky question, because firstly, the level of visibility doesn't necessarily 100% correlate with the severity of the problem. But I think the fact that it's a cracked tile doesn't also tell you how much water ingress there was. So you could have a crack there, but it depends how much water is traveling through that area. So you could have a cracked tile and there's no water ingress at all, or you could have a cracked tile and there's.
Frame that question and say, what do you have a favourite environmental intake that helps you sort of quantify that mould?
I think just other than you see, in some ways it is a little bit more of an art than a science.
Yeah.
And so it's kind of painting a picture when you ask the questions of someone, and so I think most of you who've been in this area would understand that just asking very basic and gross questions such as, do you live in a moldy building? That's not going to give you the level of information you're looking for, because also what you're dealing with people is there's a lot of preconceptions, cultural preconceptions about mold, which are not correct in terms of our understanding of how it can affect people. And so generally speaking, if you ask someone, is there mold in your home? They'll kind of take that almost as an insult of their cleanliness, and they'll say, no, of course I don't have any. Because they're not really at the same level. They're not, in terms of where you're coming from if you've studied this area. So you need to go in from the side, so to speak, and start just asking, more tangential questions. So have you noticed, or have any members of your family or people that you lived with noticed any areas that appeared to have musty smells or have visible mold, or was there any leaks that you identified? And that's just a starting point. And often they will say no to that as well. So be aware of the fact that you may not get any positive answers to start with, and you may have to dig deeper. And sometimes you ask something like, okay, so when your fatigue started in 1992, where were you living exactly? And was there any signs of dampness in that building? Sometimes people will think about it and then go, oh, hang on. Now that you mention that, so the thing is, you're not, generally speaking, most clients, unless they've read up on this area, they won't have given this area much thought. So what you're doing with your questioning is you're facilitating some deeper inquiry into this area. And you'll notice sometimes, people themselves will have a aha moment just by starting to consider those possibilities. And they'll say, hang on, now that you mention it, in 1992, that building was really damp. And that's when I developed the illness. And so, that kind of history then is very suggestive. And then it's, the next thing is, okay, so when did you leave that building and what happened then? And the classic thing was, oh yeah, I left that building and the next house was fine, but I took all my furniture with me, right? So that means that unfortunately the next building was contaminated as well. And it's unfortunate because there's just not a high level of literacy in this area. So they just may not have got the information that they needed, and therefore, they continued to have symptoms. Or in some cases you'll hear they said, no, I just left everything in that house and went to a new place that was quite good, and there was a very significant improvement. Well, that's very suggestive that mold was playing a part if they then get away from the source and there's an improvement. So it's about a very careful environmental history, and it's tricky to teach it exactly because it's as I say, it's probably more of an art than a science, because it's also assessing the person and where they're at and what their understanding level is, and tailoring your questions to that.
Yeah, good point. I hadn't thought of it in that way. That's very helpful. Thank you. So the next sort of thing I come up against all the time is limited funds.
Yeah.
And as you know, if you're starting to have to remediate houses and throw away possessions, it can get pretty expensive. So yes. I'm just wondering, if you have a client that has limited funds, do you recommend testing the house or testing themselves first? Or how, what are your priorities when there is limited money?
Okay, I'll come at this question from a slightly different angle, which is that if people are struggling with limited funds and they think they probably have mold-related illness, then often there's going to be a lot of overwhelm, and people often will sort of freeze due to the overwhelm, and they won't know what to do next, and they think it's so overwhelming and so expensive that they're never going to be able to move forward. And I think the first thing is to reassure them that there's a lot of different ways to skin a cat. And it doesn't have to be done. Like if you do it the gold standard way that the Shoemaker Group and so on were doing it with all those biomarkers and NeuroQuant and genomics and so on, it's extremely expensive. But you can, as I say, if you take a really, really careful history, my belief is you should be able to identify in the vast majority of cases when mold is playing a part. And the first thing is it's extremely common. So generally speaking, when you suspect it highly, you're usually not going to be wrong.
Yeah. Yeah.
So I would go against what some of the other experts in this area say and go as far as saying, you don't necessarily have to do, if the client is on board and understands, you don't necessarily have to do confirmatory testing in every case. That's my opinion. Others may disagree with me. If there's, if insurance is involved or you've got a legal case, then that rule doesn't apply, because no court case is going to believe that just your history was good enough to identify it. They're going to want objective data. But if it's just about working with a client and getting better, if they're convinced with the history, let's say you go back to that example that I gave, that the client, identified clearly that their illness started in a water damaged building and it got better when they got out, and that they notice now when they go into stores or markets or whatever it might be that have a water damage problem, then that on its own is actually quite diagnostic. Yeah. That they're reacting to water damaged buildings. So I would say if they're at that stage and they're on board, so to speak, then you can go straight to the building. Now, one very inexpensive thing, it should be inexpensive in most cases, is to do what's known as a mold sabbatical. Mm-hmm. Yeah, where they take usually 2 weeks or more and go camping. Now, not all people are going to be willing to do that, but it's definitely something that's worth putting on the table. Because that's another little test, if you like. So let's say, and that would be more a test in the case where they're still unwell and they're still concerned about their current building, that if you go and tent camp, and that's generally the way to do it. There are other options, but that's generally the way to do it. I mean, if you can identify a building, whether it be an Airbnb or a relative's house that you've tested and you're quite sure is clean, you could do it that way as well. But generally speaking, tent camping would be the most common way of doing it, and then just going for 2 weeks and also making sure they're not taking contaminated possessions with them. So there needs to be quite a clear protocol where they make sure they wash their clothes just beforehand with someone else's washing machine. That's another little thing I found. If they're in a contaminated house, the washing machine's usually contaminated.
Yeah.
And so it's very tricky. And
so if we feel they're in a contaminated house, is your advice then to just, in effect, remediate the house without testing? Or what role does testing play in making sure that you haven't bought mold infected?
I see. Well, the thing about
I find the least costly exercise for people.
Yeah. So, I mean, the thing is, I think you have to isolate where the problem is for remediation to be able to take place.
Yeah.
And so if you're pretty sure you've got a water damaged building, that's why you would do testing.
Yeah.
Would be to isolate. So it's a different type of testing. And so you could talk to various different mold inspectors with that in mind, that you're already pretty sure. And that changes how they might approach the inspection. So what they're doing in that case is it's particularly what you call moisture mapping is the most important part of it. The sampling, there's a question mark as to how important the sampling would be, but I think still some degree of sampling may be needed to identify which room of the house is more the problem. I mean, in some cases, it's more global than that, and that's going to be a big deal to remediate that if it's a problem involving the whole house. Sometimes it'll be rising damp, as you mentioned. Sometimes it could be a roof or attic problem. Sometimes it can be broken roof tiles, for instance. So there's all types of problems. So it could be a broken shower tile, as the example you also gave. So there's many different causes of water damage to a building. Sometimes it's just occupant behavior issues as well. Spilling over your sink or bath, or just the amount of people who are using a kitchen or bathroom causing condensation problems, especially if you're not using a proper exhaust fan or using a proper range hood. So basically, the testing, especially with the moisture mapping, is going to is going to identify, or should identify, where the moisture problem is, and one big goal is to identify, are there any active leaks. That's the number one thing. That's the first aid. You need to stop any active leaks. So once you've done that, you then need to identify the extent of contaminated building materials that need to be replaced, and that's a big thing. And a lot of mold inspectors and remediators may not be following what we consider to be proper protocols in terms of this. So you have to be very selective in terms of the mold inspector. What you don't want to do is just get anyone and then realize that hasn't been good and then pay for another one, and then realize they weren't good and then pay for another one. You want to get the right person the first time.
So what sort of questions could people ask to determine whether they are the right sort of person the first time?
Yeah. So one thing is about the qualifications. And so generally remediators should have done the IICRC training. And there's some other similar trainings for inspectors. I believe it's the AAC it's referred as. But yeah, so they want to have done some reasonably well recognized training generally. I mean, that's not 100%. If they've learnt practically from someone who knows what they're doing, that's okay too. That's the thing. Certifications aren't everything, but at least if they have been certified by a reputable body, they should have some basic knowledge. Second thing is, have they worked with CIRS or MCAS patients before? Have they worked with those who are very, very sensitive, and have they been able to identify the level of problem that allowed the patient to get better? So, do they understand what level of remediation is needed in order for people to get better who have these conditions? Because that's one of the big differences between cosmetic level inspectors or remediators and the level of inspectors or remediators that we want is basically those people who are educated at a CIRS or MCAS level. They should understand that, firstly, mold may not be visible. It may be subtle, and that even mild water damage problems could be issues for people who are highly sensitive.
And I think this is where doing your course will actually also help people to make sure that their inspector actually knows.
Yeah, we actually spend a lot of time explaining that. You're right. In the course, we go through a detailed set of questions that you can ask inspectors and also remediators. They're slightly different because the two jobs are quite different. And generally speaking, we recommend having a separate inspector and remediator, so there's no conflict of interest. However, that may not be possible in some areas. So that's the role of an inspection. They should be able to identify exactly where the water ingress has been, stop any leaks, identify the extent of contaminated building materials, and then thirdly, identify what remediation needs to be done to the contents of the house. So that's the third thing, and that very often is not done. And that they should know the difference between porous, semi-porous, and non-porous goods, and how they need to be dealt with appropriately according to their porosity, and in which, generally speaking, non-porous goods can be easily remediated, sorry, did I say that the right way around? Non-porous goods can be easily remediated, while porous goods generally cannot be.
Yeah.
So
if we come on to the testing of the person, there is an ever-increasing number of tests available on the market.
Yes.
And some, just to give you a bit of background to this question, because I have been emailed by a lot of people that are going either to a traditional doctor and getting IgE tested and told, no, you don't have mold illness, and go away. Others are asking, do I really need to know what type of mold it is in order to be treated? And then there's just a whole variety of, oats tests, a whole variety of tests with no sort of consistency being done. So my question is, are we any closer to knowing which are the most accurate and what? And as a follow-on question to the previous question, sorry for the double-barrel question, like what, with limited funds, what's the best bang for your buck in terms of testing the individual?
Okay, so it's a complex question, and I'm going to try and make it a little bit simpler by differentiating into different areas. So I consider that there are 3 or 4 different and distinct types of mold illness. Now, they can go together, so you can have more than one. Number one is mold allergy. That definitely exists, and that's what most doctors are familiar with. However, not having that doesn't mean you don't have any form of mold illness. So that's where doing IgE blood testing and skin prick testing can be useful. And if it shows up positive, often a type of desensitization can be useful. I mean, you often still have to do avoidance to a certain degree.
And does the desensitization have to be specific to that mold?
Well, at least it should include that. I mean, often you'd use a mix, but it needs to include it needs to include the molds that one's being exposed to. Yeah, absolutely.
Great, cool.
Yeah. So that's one type, and so the standard IgE testing and skin prick testing that allergists do and many general practitioners do usually will identify it. There probably is more sophisticated tests you can do with kinesiology and so on, but in general, that would tend to identify it in most cases. Now, the second thing is mold colonization in the body. That's another thing. And so the options for that are the organic acid test, where the markers 1 to 9, I believe, are all yeast and fungal colonization markers. Then you've got various types of stool microbiome tests and nasal tests. Looking directly for fungus. So you've got a nasal swab you can send to, for instance, Microbiology DX in America, and which was the original lab that was used. That's Dr. Musto is the director of that lab, who's was working quite closely with the original research team in CIRS. And then there are various stool tests such as GI Map, which is a PCR-based one, where you may be able to pick up fungal species in some cases. So based on those, that would help you decide whether antifungals, whether natural or pharmaceutical, are indicated in the case. However, again, that being negative doesn't mean you don't have a mold-related problem. So number 3 is whether you've got a mold-related inflammatory problem.
Right.
And that's what has commonly been called CIRS. I still believe that's a good name for it. Dr. Nathan was saying to me the other day he didn't think that was a great name, but I think it explains it better than anything else, because we're talking about an inflammatory response.
Yeah.
So the original tests for that were developed by the original research group were unusual tests that are not available with most labs. And that included C4A and TGF-beta 1 and MMP9, MSH, and VIP, amongst many others. And so generally, if you just turn up to your local Laverty Pathology or Douglas Hanley Moore or whatever it might be, they won't know what you're talking about.
Right. And I think for accuracy, they need to be done in the States, don't they?
Well, yeah. At this point, until we can find we can kind of get good correlation between other labs, we need to. I think it's important to go back to the gold standard, and that's part of the scientific process.
Yeah.
Is that the original research was done with certain labs, and therefore, if we change one variable, unless we validate that one to work in with the other labs, you can't assume that we'll get the same results. So at this point, yes, it would need to be LabCorp and Quest, and at this point, that's not available in Australia. I am working with Laverty, and I need to make some more calls to see, and basically someone called DHA Labs, who act as a carrier for LabCorp, and to see if we can establish a system of them working together.
Yeah, that'd be great.
Yeah, to do the labs through LabCorp. But in general, the thing about those tests is they just tell you whether you've got biotoxin-related inflammation. It doesn't actually, in my view, it's not as specific for Lyme versus mold as had been made out.
Yeah. And are there any other, so other than Lyme and other than mold, I mean, it's just showing there's inflammation. They're inflammatory markers. So are there any other things that it could be if you run those panels and there's inflammation?
Yeah, well, apparently it can just be positive with mast cell activation due to other causes such as parasites.
Yeah, yeah. Okay, cool.
So there is, yeah, there's a range of different causes, but it tends to point you in the fact that you're in that biotoxin quadrant, which is very helpful. And then you can retest, and this is more for people in America who have got insurance. It's very different for people who've got insurance and who are just near a main hospital or something like that in America. You can just go and have them drawn every few months and whatever and watch them go down or go up. One of the American mold doctors kind of emailed me her labs, and she had them done about 10 times. And, one of them jumped up, the TGF beta jumped up, and that did correlate with mold exposure. So, that's in an ideal world. But I'd say if you're in America and you have insurance coverage, I would say in that case, having these tests done does make sense because, they're not costing you extra and they're easily accessible. But I think at this point, if you're outside America, I think the UK now has established a system for doing these.
Okay.
And so maybe the UK is okay. But other than that, and maybe Canada, I'm not sure about Canada. But over and above that, anywhere else in the world, pretty much, I think it's not going to be easily available. And I know Red Labs in Belgium is doing some of these tests, but again, they're not validated. We looked at some of those in conjunction with Quest and LabCorp, and there wasn't a good correlation. So we can't recommend Red Labs at this point. So that's one type of testing.
If you are in the inflammatory quadrant, or you suspect someone is and can't access Quest Labs test, what are your options then?
Yeah. So then the next type of test is just looking for mycotoxins. And so that can be in the serum or in the urine. So fecal is not available at this stage, but I'm interested in looking into that, into fecal mycotoxin testing, because I think that's the main route of excretion. So the serum mycotoxin tests are being done by two different labs. One's called MyMyco Lab, and they're doing an antibody test. And the other one is in Germany. I'd have to pull up what the name of that lab is. I don't have it on me. But they're doing a ELISpot, which is similar to mycotoxins in the serum.
Yeah.
So that's new as well. And then you've got urinary mycotoxin testing, and that's being done with 3 laboratories. So there's Great Plains Laboratory, Real-Time Laboratories, and then Vibrant.
Yeah.
Vibrant Health, I believe it's called. So what these tests tell you, at best, is the fact that you have mycotoxins in the body. And so the just talking about urinary mycotoxins first, I mean, that has become very popular. And now some people what they're doing in functional medicine is just, you see someone and then you send off a raft of tests. And one of them is the urinary mycotoxin test. And then you see some mold toxin, you say, Eureka, I found this person's problem. It's mold. And I'm just saying, hang on a second here. Let's just settle down a little bit here. That's probably not the way to use it. I think you need to use a little bit more discernment, because essentially all it means is that some mycotoxins are being excreted, which firstly is a good thing. You want to see mycotoxins being excreted if they're there. Now, people can get incidental exposures to mold. So there does need to be some degree of controlling for environment, I think. And I think that hasn't been talked about a lot. But I think if someone's going to do a urinary mycotoxin test, they probably should do a diary of where all the different places they've gone. Because you think about it, if someone's got really, really good and working detox pathways, and they're not really got a mold problem, but they just go to a gym one day, a few days, you might see a big amount of mycotoxins in the urine, but that doesn't mean they've got a problem. That just means that they had an incidental exposure. So you want to control for the fact that you're not getting exposed to any random buildings that might be sources of mycotoxins. So that's the first thing.
Could I ask a follow-on question? I don't want to disrupt your thought, but what about people that hold on to everything?
Yeah. So that's I was going to get to that. So that's the next part of it. Is actually then if you get a negative result, that actually may be more of a concern for someone who's got a mold problem, in that they're just not excreting. They're as Alison said, they're just holding on to the mycotoxins. And so, in order to try and avoid that situation, I think Dr. Nathan and others had created a glutathione provocation test. But I think the experience is that sometimes, even with the glutathione provocation, you'll still get a negative. And I'm looking at a new type of provocation, which includes all the different detox pathways. And I'm going to include that in my next course, The Mold Illness Made Practical. But I think the actual primary pathway is glucuronidation, not glutathionation. So we needed to, so that's become clear over the last few years. So probably if we're going to do provocation, and what I want to do is discuss with Dr. Shaw and Dr. Pratt Hyatt and some other people who are involved in the laboratories, and get their take on it, and also see whether they may want to create reference ranges, because one of the concerns that I think Dr. Shaw had expressed is that, hang on, you give people glutathione, that's going to throw out all the reference ranges. It's basically, we don't know at this point what that's going to do, and maybe it might even reduce, he was thinking. So I think glutathione provocation is definitely in the not ready for the prime time basket at this point.
So can we just briefly touch on the glucuronidation pathway briefly, because I know there's been a lot of research done in that area, and a lot of my clients are, in Klinghardt terms, in blocked regulation. And a lot of those, two questions. How are you assessing whether you can actually provoke the glucuronidation pathway and not cause issues in sort of phase 1, or whether they actually need support of the glucuronidation pathway in phase 2? Because my experience of some of that research is hit and miss due to the blocked regulation in the liver. So I'm just wondering if you could talk a bit more just generally about that.
That's a very sophisticated question, and I don't know that I have the definite answer to that.
Okay.
However, but maybe you do.
No, I don't. That's why I'm asking you.
Well, I think the simplest thing is just the level of sensitivity that the client has in general would be a general guide. And I think if they're in blocked regulation, that also may be that's a term used for autonomic response testing for those who are not familiar. So those who are basically extremely sensitive, or we know have poor detoxification, you may be more hesitant in giving them a big push to their glucuronidation pathway. However, if they're reasonably tolerant of most supplements and foods and so on, you'd hope that they could take a small dose of something pushing the glucuronidation pathway, and there's many options there. And that, I'm hoping that will reduce the number of negative results in people that are, because right at the moment, without provoking, I think the chances of getting a negative result are too high for you to say, here you go, this is a great test for being able to establish whether someone has mold or not. I more think of it as a test when you've established through the history and the evaluation that it's highly likely someone has mold-related illness, to then assess whether they're excreting well or not. That's more. And so there's also this other idea that you can use the test to identify exactly which mycotoxins are affecting someone. Again, I'm not sure that at this stage you're going to get a really accurate reading of all the mycotoxins. You're only getting what they're excreting at one time. And so Dr. Nathan has also said, okay, well, maybe don't just use Great Plains or just real time, go and do both or even all three. But that, then you're going to probably get up to somewhere around 2,000 Australian. Well, I don't even think the Vibrant is available in Australia.
I think they've moved to Bloodspot.
Oh, okay. So maybe it will be, but I would guess that it would be somewhere around $2,000 or $2,500 to get all three done.
Yeah, and I mean, I think, then it becomes a question of, I just want to say one thing about the liver, but then it becomes a question of, what does that alter the way you would treat them? Like if they're excreting 10 different molds and they can't tolerate a medical binder, are you back to sort of just working with one or two at a time? But I think I just want to make a point, which is I'm finding ART testing is the only option I have for adequately assessing liver function.
Okay.
Because we used to have tests be they rather rudimentary in Australia, but those are no longer an option. And I would estimate that probably a third of my clients in blocked regulation, which I sort of see as cell danger response or, one of those cell type terms, is due to liver. So when I'm adding even some of the glucuronidation pathway supports, it's just exacerbating the situation.
Yeah.
So what are you looking at provoking the glucuronidation pathway with?
Yeah, so the main options would be calcium D-glucarate,
Right.
or astaxanthin, or
Yeah.
acid, I think it's called, which is not a very common supplement.
And if you're using, say, calcium D-glucarate, what sort of levels do you need to provoke that?
You're probably going to use around 1 gram or so, but it depends on the person.
Yeah. Okay.
It very much depends on the person. So
if we provoke them and we find out what is being excreted, does that then inform us as to how we would go about treating that pathway, the mold?
Well, the thought is then, whichever mycotoxins show up, you then tailor the binders to those mycotoxins. But see, the problem is you're not showing what isn't getting excreted, which is probably more important. And if you end up doing 2 or 3 different urinary mycotoxin tests, it's highly likely that the conclusion you're going to come up with, assuming that the client is excreting properly, is that there's a range of different mycotoxins. And so often you'll get with Great Plains, you'll see ochratoxin and mycophenolic acid and maybe some citrinin. That's the classic. It tends to have a bias for picking up those mycotoxins, while real-time laboratories will often show aflatoxin and trichothecenes and gliotoxin. So in many cases, when you do both, you'll just find that there's a bit of all 6 there.
No matter what they're excreting.
Pardon?
Does it matter then if there's mold?
Well, so then I think, and then the fact is, then there's going to possibly be other mycotoxins which are not being excreted. So is there a real benefit over and above just doing a generic binder protocol for most mycotoxins? And I would suggest there probably isn't. That's my opinion. I could be, others are saying that they really believe that doing the urinary mycotoxin test is really worthwhile, but I try and make things as easy and economical as I can. And at this point, I'm not convinced that it makes enough of a difference to worry about. I do think in some cases, like, when you've got the client has a partner who's not believing the whole thing, that's probably where the urinary mycotoxin test comes in. I mean, the classic thing is you've got a female who's affected by mold and they've got a husband who's not accepting. That's, how many times do you see that? That's the classic situation. And then sometimes, you'd almost want to do a provoked urinary mycotoxin test just to show them, there you go, there's some mold in the system. She's not making it up.
And so if you have a client that can't tolerate the medical binders, which I think bind to most mold, is that correct?
Which bind to most mold? Cholestyramine according to the research so far, it looks like the cholestyramine and cholesevelam are mainly good for the ochratoxin and mycophenolic acid, but not so much for aflatoxin and gliotoxin and trichothecenes, at least as far as we know. So therefore, but they do appear to be stronger. And one of the things about the chart that Dr. Nathan and Emily Givler and Beth O'Hara created is it looks at a range of things for ochratoxin, but it doesn't look at their relative potencies. Yeah. So I think there's certain things that might bind ochratoxin very weakly, but it may be that cholestyramine and cholesevelam are 100 or 1,000 times stronger. That's what I suspect. And so just based on that chart, you would almost say, well, why even bother using cholestyramine and cholesevelam? You would probably come to that conclusion. Yeah. And my impression clinically is that they're stronger for that part. But again, you've got to see the tolerance of the client. And particularly cholestyramine will create chaos in some people's system and put them into blocked regulation. So it's more commonly, you, for instance. Okay. So
So if a client can't tolerate the medical binders, I mean, are you rotating between the various binders, or are you doing a combo? Like, what's your starting position?
Usually doing a combo.
Yeah.
So generally speaking, there would be a combination of three, which would be charcoal and then either bentonite clay or zeolite, because I think they are quite similar if you look at their
Yeah.
coverage. So I
Yeah.
generally don't see a benefit in using both of those, and then chlorella as well.
Mm, mm, mm.
So there may be other ones that have some benefit. I'm not excluding any other possibilities, but generally a combination of those three would get the vast majority. And and they can be dosed together.
Mm.
And you're looking generally in people who have good detoxification ability and getting up to quite high doses, but in those who have very low detoxification capability, you may be just looking at an eighth of a teaspoon or something like that, and that's where it's very individualized.
Mm.
And in some people, I mean, and this is another little sidetrack, but in some people, you're going to have to look at mast cell activation before they can actually tolerate any binder therapy,
Yeah, yeah, yeah,
and also limbic system
yeah,
retraining.
yeah.
By the way, Alison, there's a heap of questions coming through. Do you want me to be
No,
going
I
through them?
think I just thought we. I know we're getting near to the end, but I just wanted to ask a question which you've touched on, and then we'll answer some questions.
Yeah, that's fine. Okay, cool. I forgot to ask. Okay.
Yeah, no, yeah, thank you. I saw them all coming through. I've got some questions. I'm listening to you. New at this webinar stuff. So one of the things I'm really interested in is, because I work in the art model, you're trained in the art model, is that things happen within a whole body. And I know that you just mentioned the need to look at the whole detoxification process. And I'm just wondering if you would sort of comment on the importance of things like liver health, emotional trauma, shutting down the autonomic nervous system, mitochondria. What are the key areas that you think we need to look at in terms of supporting our clients over and above a binder?
Yeah, so I think this is a really good question, and I think it goes back to the idea of the basic. What is the basic injury going on here? And it takes probably this question takes us away from the basic idea that have toxin, kill toxin, that it's as simple as that. Some people have looked at it in that way, and I think probably our long-term experience and research is showing that it's more complicated than just the fact that there is a toxin in the body. There's a whole range of cellular defenses that the cell undergoes in order to protect itself that need to be looked at. And so this has been referred by Robert Navio as the cell danger response. And he says that this is a very primitive response that cells undertake in order to protect themselves, and it can be either chemical or emotional trauma. And so I do feel, my observation has been, probably a better way of putting it, that many people with mold toxicity or CIRS have a background of emotional trauma. And Ashok Gupta has confirmed that his research suggests that. So the initial description of CIRS suggested that people were just genetically predisposed to it. However, he stated it's not as simple as that, and I don't believe it's as simple as that either. I think there's a emotional predisposition, and there can be a physical predisposition based on other infections and toxins and so on that you have. I do think genetics comes into it somewhere, but I think that was also oversimplified, and it's not just as simple as the HLA.
So is it as simple as something has suppressed the immune system that has made us more vulnerable to mold?
No, I don't think it's that simple. It's not I mean, if you're talking about mold colonization, maybe, yeah, then that could be like an immunosuppression type issue. But generally, when you're talking about CIRS, you're talking about an overactive immune response. And therefore, Dr. Shoemaker's research team, their hypothesis was due to HLA gene anomalies that people were then not able to have a proper antibody response. He called it antigen processing. And I still think there's something to that idea. However, more and more we look at it, it appears to not be that simple. So, for instance, looking at the MyMoco lab testing, it appears that some people who are very unwell are creating antibodies.
Yeah.
And so, as I say, there's more to it. And so there appears to be a cell danger response type of reaction, and it's more likely in people who have already had a certain type of emotional trauma, particularly around this concept of not being safe.
Interesting.
Yeah, and Ashok Gupta talks about this, and then what happens is one's limbic system is already activated and one's amygdala is already activated to a degree. Then let's say you have a problem such as mine, which is, I'm perfectly okay health wise, maybe a few minor things, and then all of a sudden I had a house flood. During the floods in Brisbane and Sunshine Coast in 2012. All of a sudden, a lot of our possessions are wet. There's mold starting to grow and be visible throughout the house. So if you then getting exposed to those mold toxins, now if you've already got a sensitivity there in your limbic system, then that limbic system is going to start, just like a fire alarm, start going beep, 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 and you're going to start getting set off, and you're going to start getting an inflammatory reaction due to that. And often in conjunction with that, you'll also have mast cell activation. And so there's that side to it, for sure, that if there's the background of, yeah.
And I mean, you're trained by Klinghardt, so am I. And I mean, the more I work with mast cell activation and cell danger response, the answers, health relies on alignment with all 5 levels, including emotional levels.
Yeah.
And don't care whether you've got issues around safety or something else. Chronic illness will bring out any unresolved issue. So I think that's a really interesting observation, that because I've recovered from mold illness, but I can relate to that issue being pre-programmed.
Okay. And yeah, so the other thing is, so as part of the cell danger response, there is a down-regulating of mitochondrial enzymes and stiffening of cell membranes that happens. So there is a downgrading of energy production that occurs, and that's just part of the cell protecting itself. There's a whole bunch of other mechanisms that it undergoes. It also pushes ATP outside the cell, and which seems to be another thing that tends to trigger mast cells. So in terms of looking at that big picture, then it's partly about reestablishing safety for the cell, and one of the ways that we do that is through doing limbic system, a focus system of limbic system retraining, so that the cell can reestablish and the person's psyche reestablishes a sense of safety, and therefore you can downregulate the oversensitivity. And then at the same time, you're trying to also get away from the toxin. So we're not saying that the toxin's not important at all.
No, you're saying in effect that the body has developed a shoot first, ask questions later approach to life based on previous, or the limbic system has, based on previous memory.
Yeah, it's got a hypersensitivity in many cases, and therefore, because the brain, and Ashok Gupta explained this, and I would recommend people check in with my webinar, which we call the Gupta Empire Strikes Back. It's on YouTube, and where we talked about there's a few Guptas around, and where we talked about the fact that the brain is, it's basically geared to survival, especially the limbic system. And so therefore, if you've had any type of severe trauma or you've had a big mold exposure, it becomes sensitized then, and even very minor, for some people, even very minor exposures then can start triggering the limbic system response. And you want to down-regulate it. And Ashok was saying you want to get to the stage where you can cope with an incidental exposure. What we're not saying is, just go on living in a water damaged building where you're getting massive amounts of trichothecenes. I mean, that's going to be a stretch to say that that's going to be good for you. But you want to get
really interesting, that association, and I can really sort of see that not only in myself but my clients.
Yeah, and it could also be an intergenerational issue as well. That was studied with regard to to Germans who had gone through, his family had gone through Holocaust and so on, and there was definitely a sensitivity there.
Yeah.
So it may not even be emotional trauma in
No,
your.
it's
It could be one
intergeneration.
that's in the
Yeah.
previous generations there. So that can definitely create a sensitivity. Well, at least we believe that's the case at this point. And the genetics of it is another little can of worms that we can go into. But there's various genetic susceptibility markers which relate to the ability to conjugate
Yeah.
mold toxins into the bile, and also relating to mast cell and iron and nitric oxide and so on. So there do seem to be some genetic predisposing factors, you could say.
Yeah. Yeah. But genetics don't drive everything.
It doesn't. No, it's not a fixed thing. That's the thing. Modern medicine is taught that your genetics are fixed and there's nothing you can do about it. While we're teaching that genetics are probably to do with your previous generations again, and what their health habits have been and what their exposures have been like. And therefore, you're not only dealing with yourself and your history, you're dealing with your whole ancestral line history. And so there could be some weaknesses there that have been brought on by previous generations, and you may have to also account for those as well as part of your healing. It's a big deal, healing.
Yeah. Yeah. But it's absolutely possible. I mean,
It's absolutely
I look
possible.
at where I've come from.
Yeah.
You know, I had a brain injury. I was like a little old lady in a nursing home. I couldn't find my way home, and now I'm helping other people. So regardless of where people are, there's real opportunity for healing. I'm conscious of your time because I know you're in clinic today.
Okay, no problem.
Time to answer a few questions.
Yeah, sure. Yeah.
Yeah.
Yeah, I don't have any clients straight after this, by the way.
Okay, awesome. So, will we just start at the top?
Sure.
And do a rapid answer.
Rapid fire.
Is there a more natural option than question light?
Yeah, I think we covered this briefly, but basically you can use a combination of natural binders, including bentonite clay or zeolite, charcoal, and chlorella. I think that's a good start. And there are some combinations, products out there you could use to at least cover the charcoal and bentonite part.
Okay, cool. The next question is about neuroquant reports. What information indicates mold issues? Does it always correlate with cognitive issues?
Yeah, so this is an evolving area, and Dr. Shoemaker and Dr. McMahon wrote a paper probably around 2010, and that was just using what's called the General Neuroquant Report, which wasn't age and sex matched. But since then, the Cortex lab who produced the Neuroquant reports have created something called a triage brain atrophy report, and that is age and sex match. And since we've been looking at results under that microscope, we've found that the original scoring system by Shoemaker and McMahon isn't really holding up. And therefore, we're looking at getting published, in the ICI group, which is the International Society of Environmentally Acquired Illness, is looking at getting published a new scoring system. And Dr. Ackerley and Dr. Gazda, particularly, who are actually neuropsychiatrists and neurologists, respectively, have looked at a new system. And so basically what you can look at with neuroquant, the first thing is to make sure someone doesn't have actual dementia or Alzheimer's disease, and that's why you look at something called the age-related atrophy report. Secondly, the general report is more looking for asymmetry. So if you've got significant asymmetry, you're thinking about traumatic brain injury, which can cause a form of CRS as well. And interestingly, I have seen in some clients that could be the reason they don't respond, is they've actually got a traumatic brain injury, as well as mold toxicity. So that's very useful to the neuroquant can be very useful for excluding that. And then thirdly, on the triage brain atrophy, then you get to look at which areas of the brain are significantly enlarged or shrunken. And so the classic thing that we're seeing with mold is enlargement of thalamus, the anterior cingulate, and the amygdala, and sometimes the hippocampus. And so there's a slightly different distribution in post-Lyme syndrome. And then mast cell activation is similar in that it can affect the amygdala and thalamus and hippocampus as well in those areas of the limbic system. So one thing is that if you've clearly got involvement of the amygdala and other areas of the limbic system, we almost always will recommend limbic system retraining. And we feel that that seeing that is really helpful for then the motivation to go and do the limbic system retraining. In some areas, then there are other. So if there's a lot of atrophy, we then start recommending specific neurotropic supplements and medications to help with the regrowth of the brain, and sometimes VIP nasal spray is included in that. And then sometimes there's other things like PTSD signs as well that can be picked up on Neuroquant. That's a bit more subtle. So it's interesting. It's an evolving area. It's not that definitive. Like, you can't, generally speaking, you won't do a Neuroquant and say, oh, there you go, it's mold, or there you go, it's Lyme. It's not quite that simple, but it gives you an indication, and it gives you certain areas to look into, and then you can follow up with that. So it's interesting, and it's a more, you could say it's a more specialized area. And certain people do consult me for that, or consult Dr. Ackley or Gazda.
Awesome. When washing clothes and fabric items, is there something specific you need to wash them in to get rid of potential mold exposure?
Not really, no. I think just washing them with a detergent is fine. You can use borax or vinegar, but again, in general, the key is we're not trying to kill mold spores in general. We're trying to physically remove it, and the scrubbing that a washing machine does is perfectly adequate. If it's just a few little mold spores, you're not talking about visible mold. Generally speaking, if you see visible mold on the clothes, it's best to just discard it.
Yeah. If there's been water damage in the ceiling structure due to damaged roof tiles, do you replace the ceiling structure such as the joists as well as ceiling lining boards if water damaged? I mean, this might be a bit too specific, but just as a general comment, how do you know how much?
So that's part of the moisture mapping that's done. And so if you see high moisture over any porous material, so the thing about joist and particle board and so on, which is most used in Australia, and I think in America it's NDF, is used. Well, they're porous materials. So if they've been wet, they are contaminated and need to be removed. Simple as that. But again, it's a fine art in working out the exact extent of what needs to be removed, and that's where you need a good remediator.
Yeah. How long can mold colonization persist in the body post-exposure to a water-damaged building if not treated?
Or it can last forever. if you don't have a good functioning immune system.
Doesn't go, it's staying there. Let me just quickly go through these. If the home is remediated and UV is used to clean everything, are possessions okay, or do they still have to be discarded? So I guess the question is, how efficient is UV light?
No, the UV won't replace the need to remediate the possessions. That's just going to help a little bit with, I guess when you're saying UV, you're talking about like a photocatalytic air purifier, which uses UV light. So that will help with just any incidental mold moving around in the air. But it's not going to help. So the problem is, you have a look at this, these sofa chairs behind me, for instance. If we'd had major mold contamination in this room, the mold is inside it, and it may not be moving around at all. It's not like the mold is just kind of going free flowing. It may be stuck in there, and therefore it may not be available with the rest of the airflow to be oxidized. That's what you're doing with the UV light, is oxidizing mold. And it can also just be particles or byproducts and things that are not so easy to oxidize. And so basically at this point, we don't have any technology that's 100% guaranteed to remediate this. I mean, we're looking at various things such as dry ice blasting and gamma irradiation and all sorts of things like that. But at this point, we don't have enough data to say that it's okay. And so if you had a contaminated room here, let's say I'd had something in the walls here and there was a major mold problem, well, you just as part of the remediation, these would have to go. This leather chair here, you'd have to check, is there a porous underlay, which there usually is, in which case it would have to go. If it's well sealed, you could just consider this semi-porous and clean it really well and HEPA vacuum it, and so on. You know, that painting again would be porous. And again, while the computers and printers and so on in here would be generally considered non-porous, you'd have to open them right up and clean them as thoroughly as possible with a HEPA vacuum, but you should be able to keep them. So that's basically the protocol.
Protocol, yeah. I think some of these questions we've answered.
Yeah.
Yes, there'll be a recording. I'm sending out the recording. Activated charcoal is often prescribed for 3 to 6 months. However, CleanCut tells us not to do this because charcoal binds to everything. You suggest to use it only acutely for a few days. Can you please comment?
I think it depends what dosage, but yeah, it is something that will bind a whole lot more than just mold. I'd agree with that.
Yeah.
And especially if you're having it with meals, you could be binding a lot of food particles and so on. So yeah, I would say charcoal is generally something you should rotate through. You
Mind you,
certainly forever, and even more so cholestyramine actually.
yeah, mind you, I'd rather get rid of the mold. So
Yeah, that's true as well. You know, you can. Yeah, that's the thing is you. So there's a bit of a balance. I think a few days is possibly a little bit. You know, that may be a bit extreme.
yeah.
Yeah.
Does it matter where we get the oat test done? My doctor directed me to Great Plains Labs, but this is not covered by my insurance. So I think there's Genova and there's Great Plains, but I think it's
Oh, they're saying what's they saying? LabCorp. Yeah. Well, the general organic acid tests, which are done by more conventional laboratories, are more looking for inborn errors of metabolism and so on, and they're almost always be normal. So it's very different. Yeah, the oat with Great Plains Lab can't be. I haven't specifically seen one done by LabCorp, so I'm making an assumption here, but most likely it'll be correct that they'll just be looking at more general genetic markers for inborn errors of metabolism. And so, yeah, you'd want to do Great Plains Lab because the thing about and actually, this is actually a really important point I wanted to make before that if you want to just do one test, probably the organic acid test by Great Plains is the one because it gives you information on whether there's colonization. Secondarily, oxalates. Do you have oxalates present? Thirdly, it also bacterial colonization is very common, and even Clostridium problems are fairly common in mold. So you actually do want that info. You do want the info on the mitochondria, and the and also the what we call the neuro transmitters, and to see whether there's a dopamine problem or something else going on. And then there's a whole bunch of information about nutrients such as B vitamins and also fat metabolism. All of that's very useful. And then so I would say in terms of bang for your buck, the organic acid test by Great Plains is very worth it. I think there's 100 or more markers in there.
Yeah, I agree.
I think that's
about as close to a full body scan as you're going to get on one test.
Yeah, exactly. And there are now some more specific markers, according to Dr. Pratt Hyatt, who doesn't actually work for Great Plains anymore. So I don't think he's got a bias there. And he's saying if you've got a high lactate, that's quite specific for mold. If you've got a high, come on, brain, it's, let me see. Is it mandelic? No, mandelic is the mandelic acid is the chemical marker, and the one I'm thinking of is succinic acid. There we go. So if you've got a high succinic acid, then that generally indicates either mold or chemical toxicity. And then lastly, a low pyroglutamate is quite specific for mold, he says. So if you see those markers, I think that's probably almost as good as getting the Quest and LabCorp TGF beta and all of that. So I think the organic acid test is the most economical and useful out of all of those. It's only a couple of dollars per marker. If you think of it that way, I
didn't know about those added interpretations, so that's really interesting. I'll go back through some of the ones I have and highlight that. Can you address red light therapy for detox?
Yeah, red light therapy is very healing. Infrared. And particularly for some people, one block is that they're just not able to drain their brain effectively. They're not able to detoxify their brain. So giving some red light on the brain is quite a good strategy for that. Sometimes using a circulation cream for the neck is quite useful. And there's other little tricks that are sometimes used in ART and so on.
Yeah, so it's just the ART ones. Yeah. Okay, cool. Now, here's one of my favorite questions.
Yeah.
Ozone.
Ozone, yeah.
On ozone to remediate houses and furniture. can it be used and then HEPA vacuumed afterwards?
Okay, so I've answered this one a fair bit lately, but I'll do it again. No probs. So ozone is basically an oxidizing agent. It's very, very useful as an internal agent. So it can be used rectally, it can be used in the ears and in the nasal passages. Very useful for bugs in the body of all kinds, including fungal colonization. However, we don't think it helps in getting rid of mycotoxins. That's the first bit in the body in general. Now, when you're using ozone for a building, it's going to oxidize mold that's present there. But then what happens is it breaks it down to the particles and so on, and they float onto they settle down on surfaces. So it could temporarily mean that someone then reacts less for a while. But the problem is if you've got an active source of contamination. So again, think of this room that I'm in, and if there was a water leak in this wall here, and you've still got contaminated building materials there, they're off gassing all the time.
Mm.
So if you've gone and then ozoned the room, okay, it's just like giving it a quick clean, but then the source is still there. It's like you've got a boat that's leaking.
Yeah.
And let's say someone comes in and says, hey, here we go. We've got a great little cup or a great little mug that we can use to get some water out. So you've done that. All of a sudden, let's say you grab this huge bowl or mug and you got a lot of water out. But then you look back down at the boat and it's like, oh, okay, it's still leaking. So
funny about that.
Yeah, funny about that. So, that's the thing. So you've got to deal with the source. So if sometimes I do realize that remediation is very difficult and expensive, and so sometimes as a temporizing measure, it certainly can be used. And there's other temporary things that can be done, like air filtering and putting away all your papers and porous goods into like plastic boxes, and there's some other things like that you can use just in order to buy some time while waiting for remediation to happen. And I'm not saying that, that's a possibility. I mean, I had my house gassed when it was originally contaminated, but that wasn't the key. The key was actually getting out of the house and dealing with all of the possessions. And so, yep, that's it doesn't, basically the answer is it doesn't replace the gold standard, but it can be used as a temporary, a buying time kind of measure.
I'm just conscious of times, just lightning round on a few things. Can anyone get mast cell symptoms controlled without first addressing mold?
Yeah, you can. You can get them controlled, but you can't get rid of them forever.
Mm.
So generally you would treat mast cell first, and then you go for the cause, yeah.
The next is about nasal congestion, and I'm actually just going to alter this question a bit because I think it'll be helpful. Elke is asking about nasal congestion and what works, and she's mentioning various sprays and whatnot. I'm just wondering if you've used Briotech in that way, because I personally have found that successful, or what else do you use for fungal colonization in the nose?
Sorry, which substance did you ask about?
Have you used Briotech before?
Briotex.
Yeah, Briotech, HOC.
Oh, okay. Yes. Well, I've used it for myself.
Yeah.
Personally, just using it as a sinus rinse. And yeah, so I mean, that's a very general antimicrobial, which can be quite useful. And so I want to just take a step back with this question and just say that we're now looking at the ICI group are looking at the nasal biome in a more holistic way. And so rather than just thinking about MARCoNS, we're thinking about dysbiosis in general, and going back to more like a weed, seed, and feed type approach, where we would, then sometimes use something like biocidin and probiotics, as you mentioned. If it's been unsuccessful, as you say here, then probably doing some testing is worthwhile, because maybe there is a more strong dysbiosis that may need to be addressed. And I'm not saying that using some of the old treatments like Beg nasal sprays might not ever need to be used, but in general, they're just not the go-to anymore. So maybe if someone had a very, very severe dysbiosis there with MARCoNS or something else, maybe it's still in some cases would need to be used.
Yeah. Okay. Yeah, no, I know personally using the Briotech has really helped me. I know everyone's different. and I'd be very interested to see. I'm a big fan of the whole biome, so it'd be interesting to see where that work goes. I'm not going to answer questions about specific buildings, but just one final question. Best therapies outside of traditional Shoemaker protocol for improving mold-related neurological symptoms such as brain fog and lack of
Let me think about that for a second. Yeah, I think possibly one would go and look at the Patricia Kane protocol. There's something to look at with the phosphatidylcholine and NADH, or NAD plus rather, and butyrate. For some people, that can give a lot of benefit in getting the brain fog better. I still think you've always got to think of the cause. Like if someone's got a lot of that left over, you still got to think, do they have tick-borne infections? Do they have something else going on? So if there's any unresolved causes there, nothing's going to work particularly well. But if it's just residual damage, I would say the phosphatidylcholine and so on is very good for rebuilding neuron cell membranes, and you could do that IV and oral.
Okay, awesome. Okay, well, thank you so much. I mean, I just feel personally this space is moving so quickly, and I really genuinely appreciate all the work that you and your colleagues are doing to get things much clearer and much more precise. If I even think about where we've come from when Dr. Shoemaker started this process, the space is moving pretty quickly.
Yes.
And I really appreciate everything you're doing to help us find a way forward. And I just want to say to everyone that really, if you are struggling with mold illness, please consider doing Dr. Gupta's course, which is Mold Illness Made Simple. We're all in different environments. The space is moving so quickly. It is one area where we actually need to be really well informed ourselves. And I know that can be hard when you've got brain fog and fatigue and everything else, but please do consider doing it. I know me doing it enabled me to manage the remediation of my building, the choosing and so on. And just to make life easier, Dr. Gupta has very kindly offered a 25% discount, and all you need to do is put in low histamine 25 and you will get a 25% discount. So thank you.
No worries. Yeah.
I appreciate everything you're doing and for spending the time with us.
You're very welcome. And I just want to encourage people, if they're dealing with clients with mold illness and they're finding that it's frustrating and difficult, don't give up. Keep working on it. There are many different answers that have come in over the last few years that can really help people. And so keep a broad net around this, and just basically also use your intuition. That's going to be very, very important in there. It's not always as simple as a solely kind of biochemical paradigm would make you think. And sometimes sometimes people may have seen 10 or 20 other doctors, including some of the most famous ones in the world, but maybe it's you that cracks the case if you just apply your full common sense and intuition and your empathy to it. So I just want to encourage everyone.
And everyone's sending messages saying thank you very much. So thank you, and everyone will be sending a recording out to everyone that registered, and thank you once again.
Thanks, Alison.